Ear Surgery and Approaches by P.L. Dhingra, Chapter 79. Introduction to Ear and Mastoid Surgery. Terminology for operations performed for chronic ear infections. Myringoplasty. It is an operation in which reconstructive procedure is limited to repair of tympanic membrane perforation. Tympanoplasty without mastoidectomy. Tympanum equal to middle ear. It is an operation to eradicate disease in the middle ear and to reconstruct the hearing mechanism without mastoid surgery, with or without tympanic membrane grafting. This means ossicular reconstruction only or ossicular reconstruction with myringoplasty. Tympanoplasty with mastoidectomy. It is an operation to eradicate disease in both the mastoid and middle ear cavity and to reconstruct the hearing mechanism with or without tympanic membrane grafting. Cortical mastoidectomy or simple mastoidectomy or Schwartz operation. It is an excenteration of all accessible mastoid air cells, preserving the posterior meatal wall. Modified radical mastoidectomy. It is an operation to eradicate disease of the attic and mastoid, both of which are exteriorized into the external auditory canal by removing the posterior meatal and lateral attic walls. Tympanic membrane remnant, functioning ossicles, and the reversible mucosa and function of the eustachian tube are preserved. These structures are necessary to reconstruct hearing mechanism at the time of surgery or in a second stage operation. Radical mastoidectomy. It is an operation to eradicate disease of the middle ear and mastoid, in which mastoid, middle ear, attic, and antrum are exteriorized into the external ear by removing of posterior meatal wall. All remnants of the tympanic membrane, ossicles including malleus and incus, but not the stapes, chorda tympani, and mucoperiosteal lining are removed, and the opening of the eustachian tube is closed by packing a piece of muscle or cartilage into it. Meatoplasty. Meatoplasty is an operation in which a crescent of conchal cartilage is excised to widen the meatus. It is invariably combined with all canal wall down procedures, that is, modified radical and radical mastoidectomies for easy access to mastoid cavity for periodic inspection and cleaning. It is also done as an isolated procedure in a sagging auricle seen in older patients. Sagging auricle obstructs the ear canal and causes hearing loss and retention of wax. Mastoid obliteration. It is an operation to eradicate mastoid disease when present and to obliterate the mastoid cavity. Obliteration of mastoid cavity is done with pedicle temporalis muscle or musculofacial tissue raised flaps. Surgical approaches to the ear and incisions. Endomeatal or transcanal approach. It is used to raise the tympanomeatal flap in order to expose the middle ear. Rosen's incision is the most commonly used for sepidoctomy. It requires the meatus and canal to be wide enough to work. It consists of two parts. One, a small vertical incision at 12 o'clock position near the annulus, and two, a curvilinear incision starting at 6 o'clock position to meet the first incision in the posterior superior region of the canal, 5 to 7 millimeter away from the annulus. Posterior meatal canal skin is raised in continuity with tympanic membrane. After dislocating the annulus from the sulcus, it gives a good view of the middle ear and ossicles. Stapes, if covered by posterior superior overhang of bony meatus, can be exposed by removing this part of overhang. This incision is also used commonly for exploratory tympanotomy to find the cause of conductive hearing loss, inlay myringoplasty, or ossicular reconstructions. Figure 79.1, Rosen's incision for tympanotomy, 5 to 7 millimeter. Endoral approach. It is used for A. Excision of osteomas or exostosis of ear canal. B. Large tympanic membrane perforations. C. Attic cholesteatomas with limited extension into the antrum. A. Lempert endoral incision. B. Lampert 1 and Lampert 2 from 12 o'clock to 6 o'clock position. Figure 79.2 endoral Lempert's incision. A. Incision into the canal and incisura terminalis. Big magnified view of A. Note position of Lempert 1 and Lempert 2 incision. Figure 79.3 types of post-auricular incision. A. Sulcus incision. B. Post-oral incision in adults. C. Post-oral incision in infants. D. Modified radical mastoidectomy, where disease is limited to attic antrum and part of mastoid. Endoral approach is made through Lempert's incision. It consists of two parts. Lempert 1, it is a semicircular incision made from 12 o'clock to 6 o'clock position in the posterior meatal wall at the bony cartilaginous junction. Lempert 2 starts from the first incision at 12 o'clock and then passes upwards in a curvilinear fashion between the tragus and the crust of helix. It passes through the incisura terminalis and thus does not cut the cartilage. Both mastoid and external canal surgery can be done. 3. Post-oral or Weil's incision. It starts at the highest attachment of the pinna, follows the curve of retroauricular groove lying 1 centimeter behind it, and ends at the mastoid tip in infants and children up to 2 years of age. The mastoid process is not developed and the facial nerve lies exposed near its exit, and the incision therefore is slanting posteriorly, avoiding lower part of the mastoid. Some surgeons prefer to make the post-oral incision in the sulcus post-auricular groove. Post-oral incision is used for cortical mastoidectomy, modified radical and radical mastoidectomy, tympanoplasty when perforation extends anterior to handle of malleus. D. Exposure of cranial nerve 7 in vertical segment. E. Surgery of endolymphatic sac. Thank you.